Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Yeah, I've been listening for, I think, a couple of years now.
Oh, well, thank you.
Yeah.
And you work flight,
Yeah.
and we were talking about people being unprepared and just getting pushed through orientation, which seems to be a problem in a lot of places. A lot of unprepared people coming out into the workforce. So, do you want to tell me about what sparked you to send me a message? And then I was like, you know what? Why don't you come on the podcast and talk about this? Because I've heard this from many other people before.
Yeah. I have had a little bit of that experience that I've seen on the ground side. Where I used to work, they have an academy where they push an EMT academy essentially, and then they come and work the street. And those kids are really bright young kids, like 100% probably have a lot of potential and things like that. But the adjustment to EMS is they call it a lifestyle, and that's so cheesy, but it really is trying to adjust to just running a call. I mean, you don't even have to be medically smart to go through a call, to be honest with you. It's just like the flow of things and kind of just moving the call along. That can be the hardest part for them to adjust to. And then in the flight world, I noticed that it's kind of the same thing. Very, very, very medically intelligent people. Like they can list off every single number that you're looking for on your Ravel vent or on your Hamilton vent, or like they're just like gurus when it comes to this medical stuff, and they can list out everything you need to know on your protocols or anything like that. But when it comes to like actually running a call, they seem to struggle a little bit with more of like just being around the environment, like the aircraft or the ambulance. So I feel like they have a very difficult time with the adjustment in that aspect.
Do you see this, dare I say, more in nurses than in paramedics?
Not really. I feel like it's in both.
Okay,
Um,
fair.
I
Do you want
definitely
Go ahead.
think being around an aircraft is like shell shock. Like people like have no idea how to act.
It is a very disorienting environment. It's loud. There's flickering lights. The flicker vertigo is a real thing. The vibration fatigue is a real thing.
Right.
And that's not something that you're prepared for. There's not a good way to train for that.
Yeah, and then you're throwing in these 24-hour shifts, which EMS and nurses are really not used to doing, and not every medic that you hire is a fire medic that works 24-hour shifts. So then you're throwing them in these environments in the middle of the night with NVGs, and then they also have to critically think about medicine. So it's a lot, and I think like I said, I think medically when you get hired, well, speaking about flight specifically, I've brought up when you get hired, you pass a test, or you should be passing your test, like your entry exam, and it has a
You
lot
had
of
an
critical
entry
care.
exam.
Yes. And it has a lot of
Interesting.
it has a lot of information that there is general paramedicine on there and general nursing on there, but there is critical care topics on there like um head bleeds and treatments. The vent stuff was a little bit more generic, like just the math for your tidal volumes and stuff like that and PEEP values. Like the entry test is more than just regular paramedicine or regular nursing. Like there's definitely some critical care in it, but it's not as deeply involved as like the FPC is. And then you take scenarios as well. So when you get hired, those are the two programs that I've worked for that offered. Those were both situations I had to go to get picked and hired. And so when I think about that, I'm hired at some sort of medical level. So you know that I have this baseline of some sort. Hopefully, I'm pretty sure I passed the test, and I hope everyone they hire passes these tests. But like you know that I have this baseline in me, but I've never been around an aircraft before.
It's interesting. I get asked constantly, and I'm sure you do. I want to get into flight. How do I need critical care experience? And my experience, like you, I've worked for two teams now. And it's always been you don't need critical care experience. It was always we just want a good paramedic or we just want a good nurse with valuable experience and we can train the paramedic in the critical care stuff. So it's interesting to hear, and you work for a very large company. So
Yes.
it's interesting to hear, and I guess it's good for all the people who listen who want to do flight to hear that maybe you do need some critical care knowledge. Maybe I need to adjust my thinking in that when I tell people, you should just be good at your job and worry about that. They'll train you up.
Yeah, there's some topics on there that I would consider critical care. Well, like things that I studied for an FPC to test for. I definitely saw it on my entry exams for both jobs.
Okay.
Um, but with that being said, then you should be hiring people that you know have this medical level, at least some bit. Um, and because of that, I think maybe it's important to focus more on the operations training as opposed to some medical training initially. Because you know that they have this baseline of some sort to run probably about 80% of your calls. Yeah, I've heard you before say a lot of the stuff that we do in flight sometimes isn't as critical care as people think it is.
I was going to say that.
Yeah.
They ask you about all of these complex critical care things. Like on the FPC, it's all the hemodynamic values and the Swan GADs and ventriculostomies. And we don't do a lot of that. I mean, how many, just asking you to estimate, of the flights you do, how many would you say are like really challenging thinking flights?
Well, my job that I left about 6 months ago, I would say at least once or twice a week, I had something that involved some critical care thinking with my
Yes.
partner where we were going head to head, compromising, doing good decision making at least once or twice a week. We were doing critical thinking, but now in the population I work in now, I haven't ran a critical call probably in 6 months that I think required my significant critical thinking skills. I haven't
Are you
ran one
being
in.
used? Are you being used primarily because of the geography?
Yeah, we do a lot of distance. I mean, the hospitals where I work are they don't some of them don't even have labs. I mean, like, we're
That's
moving
wild.
it's insane, it's actually crazy. We're moving, like, some really not sick patients, um, and yeah, so we haven't had a lot of sick, patients in a while. I've had a couple. I picked up some stuff over on the other side of the country for a little bit, and I had a couple of good patients there. But again, it was more of like, okay, I know how to turn the vent on. I know how to put it in the aircraft. I work well with my partner. I know the flow and things like that. There really wasn't much like significant critical thinking of medicine going on. Um, but it was more of like my familiarity with the aircraft and the equipment.
So now that you have some experience, do you think we're getting a lot of people who are brainiacs that don't know the, I guess, quote unquote, common sense of how to run a call? Is that what you're
Uh,
seeing?
I think that that can happen, because they look really, really good on paper and they still are very intelligent people, but trying to teach someone to go with the flow that's, like, that intelligent and that type A is very difficult.
We all know the type who have all the knowledge in the world and all of the letters after their names, and they can't do the job. I just recorded before coming on here an episode where I talk about VTAC and how it's underdiagnosed.
Oh,
And you
yeah.
see this, you have these people who they have all of the knowledge in the world and they will whip out this like, well, it could be a left anterior distal hemi block with an RSR prime and there's
Yeah.
negative concordance. And it's like, motherfucker, the patient's in a wide complex tack with a pressure of 60 in front of you. Do something.
It's
It's like
wide and fast.
you got all this knowledge, but they can't apply it.
Yeah.
Another thing I see from people that are coming off of orientation. And this, if anybody at my job is listening, I am not necessarily talking about you, so don't get butthurt. But generally, I see people who don't have social skills coming off of these orientations. And this is a talking job. This job is 85 to 90% talking to people.
Yeah.
And we're hiring people that don't know how to do that and don't know how to interact with people. and motivate people. How do you tackle that on orientation, though?
This is something that maybe other people that have trained me and work with me might not specifically agree with, but I think that it's really important to drill in the distance and speed. Like, we're here for distance and we're here for speed, and if you're not fast, then essentially you're kind of useless sometimes. For us, it's definitely distance out here. Speed is important too, but when I was working on the East Coast, if we were not fast, we had people tapping at their watches at us. We had,
Same.
like, we're moving strokes and stemmies. If we don't move them fast, then they could have worse deficits, I guess you could say, than what they would be if they just sat here. Um, Something that I try to talk to my team about is we're here for distance and speed. And I understand that our scope is wider sometimes, but that doesn't mean that that's why you're there. I definitely try to hone in on that a lot. There is some disagreements because of the community that we work in. Um, but we are there for speed, and that's the end of it. And I've also said, like, all these all of these companies compete. Everyone's like, these are our customers. We have contracts here, we have contracts there, because that's essentially how it works. But at the end of the day, if you move that patient fast and open that bed up for another one to go in, then you did a good job.
Yes. Uh, I would imagine this is something that you're going to catch shit for saying, because our community, I think, can sometimes be very self-important, and they think we are the ultimate level in critical care because we are in a helicopter and we wear this silly outfit. And uh, I'm not a nurse, but I would imagine that if I was a nurse, nothing would make me more apoplectic than having some flight crew come, ask for like 200 more ABGs, stay at the bedside, start their own lines, request additional labs when you're going to fly the patient 45 minutes to definitive care. Like, yes, are there sometimes we need to stay at the bedside and stabilize the patient? Yeah, because you don't want them crashing and burning in the helicopter, because it's a pain in the ass to manage a patient in the helicopter, and you can't effectively code or not optimally manage a crashing patient in that confined space, especially like at night when you're flying through the dark. The lighting in the helicopter sucks. Yeah, so I get you want to stabilize the patient at the bedside as best you can. But I look at some of these crews, I'm like, what the hell are you doing? Just put them on the stretcher and take them to the friggin' hospital. Like, as you said, time is brain, time is muscle. You know, do you really think that you're going to reverse their condition here? Like, yeah, sometimes we correct things. They call it a well-lit scene call. But I think you
But
hit the
in
nail on the head.
I mean, it's the same thing you do in the back of an ambulance when you show up to someone's house. I mean, it's airway, breathing, and circulation with resuscitation. So, and then there is the argument, like, too sick to fly. There are some people that do that, and
What
I know.
what are your
But
thoughts on that? I'd like to hear your perspective.
that argument, that situation, I don't necessarily agree with. Like, when you know what they need and how to get them there, I feel like you owe it to that person or that family, or it's just morally correct to get them somewhere.
The
I don't know.
first team the first team I was on, there were 2 camps. There was, dare I say, the younger crowd who was like us, and I think a little more aggressive. And then there was, I don't know if aggressive is the right word. Maybe we had more of that moral obligation philosophy. And then there was a bunch of crusty old people who had been on the team since its inception, and they were real big on this too sick to fly. So a team consisting of a young nurse and a younger paramedic, very good crew, I think, but they were inexperienced. They flew this guy with an aortic dissection who was peri-arrest with a pressure of 40, who had already been resuscitated pretty maximally at the referring facility. And they said, fuck it, put him on the stretcher and let's take him to the OR. And man, the crap they got. How dare you guys be so irresponsible? The assistant nurse manager was up their ass. The QA person was up their ass. That how dare you put this person on a helicopter and fly them when they were this unstable? And thank the Lord, we had a kind of younger, came from the military medical director who had come onto the team. And he was like, no, they absolutely should have put this guy on the helicopter. This man was going to die. And the only thing that was his chance for survival was a surgeon that was not at that sending facility. So probably going to die, might as well die with a fighting chance on the way to a surgeon.
Right. Yeah. And I feel like that, like, that also has to do with the way you document things. You could be like, I understand the instability of this patient. However, we talked about it and we decided this, and that's why we did what we did. But I think the flight world is trying to get away from the too sick to fly thing by putting
Right.
on, we have an auto pulse now. So I think that has a little bit to do with to try and help that. Um, but there have been some situations, like, we've had people with pressures of nothing on nothing, and the facilities here can't even do art lines. So if you have an art line, you have a little bit of a better idea of a blood pressure than just, like, your regular blood pressure and stuff like that. That can really help with someone being too sick to fly. Um, but I don't really like this too sick to fly excuse. It's
We
not
don't
something.
have an We don't have an auto pulse. What I recommended that we get one or a Lucas device, especially because we're the only flight program in our area that will fly trauma arrests. Like, we make a specific point that we're not scraping up meat off of the highway and piling it onto the stretcher, but our protocol is that if we're at the scene of a trauma and they arrest in front of us, we're to fly them. And I know that we're getting away from compressions and trauma. I hope we get away from them totally. That would be great. But for now, we're doing compressions. And I said that if we're going to be flying these trauma arrests and we want to do it meaningfully, we should have an auto pulse or a Lucas device. And we were told that space is a big consideration.
It's a nightmare. It is a night
Is it?
it is not easy. It is not, we had to
Okay.
move a
So
lot of
it's,
things around. There's a weight issue. Um, we have to get approval to leave it. If we get a patient's weight to accept a flight and we have to leave that behind in case the patient it might be too much weight, we have to ask permission or notify them that we're leaving it behind. Not really
okay.
ask permission, but there's, like,
Maybe I was wrong to roll my eyes when they said that space and weight was a consideration.
Yeah, it can be, but we had a Lucas device at the other program I worked for, and it wasn't that big of a deal as it is here, like, leaving it behind and everything like that. It was more of a, like, if you're going to pick up a STEMI or it's like like, they give you notes, right? Like, ROSC and STEMI or STEMI, like, you probably should bring the Lucas with you. Things like
Yeah.
that. You would make common sense decisions as providers, which you were hired to do because of your experience, to take things with you to prepare for these calls. And that's kind of the way that company that I saw utilized the Lucas device.
Would you ever have patients that were awake and you're putting the back of the Lucas or the auto pulse behind them, waiting for the inevitable? And the patient
No.
would say, what is this thing you're putting behind me?
No, but I did have it with pads. They'd be like, "Why are you putting these pads on me?" And I'm like, "Oh, well, you always put pads on your stomach before you fly because you never know you never know when you're gonna have to shock
Yeah.
your STEM patient."
I'm putting
But
pads on you because I'm scared shitless right now.
yeah. And, well, yeah, for sure, and then you have to tell your pilot, "Hey, take your hands off the little thing in case the patient's, like, touching it," and then you shock your patient and the pilot. That's not gonna go very well,
Yeah.
but
So we
but
came
yeah.
way off topic from
I know,
orienting
sorry.
people. No, no, these are the best podcasts. The best podcasts are the ones that really have no script and they just go
Yeah,
wherever they go. So how do we fix the problem of people coming off having no common sense and no direction for how to run a call? Because that's a very broad thing.
yeah, and it is very broad, and sometimes, not to be negative, some people just never get it. It
No, that's
never,
a fact.
and and those are really difficult people. I'm talking about ground mostly, that my experience has
Okay.
been usually flight-wise. If they don't do well with the scene rotor, you can find somewhere for them to do some fixed wing stuff where they'll be very intelligent people and do really good jobs and you can find.
Are you saying fixed wing is a pasture?
No. No, but like I feel like it's these young kids that come into EMS that just have a really hard time adjusting to seeing these things that they've never seen before. And in the speed they've never done things before. To fix it, I mean, I've seen people just pushed through and pushed through and pushed through,
Yes.
and then it takes a big toll on your really good trainers and paramedics, and then they quit,
Yeah.
or they go somewhere else where their ideas are listened to. Because these people that quit aren't like, "Oh, that was hard. I'm just gonna quit." You know that they went to their trainers and were like, "You need to fix this because this is ridiculous. Like, we can't be pushing these people through this far, and you can't tell me to be the a-hole that has to go and tell them, maybe you should do something else with your life." Like, these poor kids put so much effort for them, this is so much effort that they're putting in for something that's a career for them at that point. I mean, when they're that young. But I think I like to focus on ops with these people first. Um, Putting the ambulance in drive, driving to a call, parking it at the gas station on the corner when you're waiting for your call, teaching them how to use the CAD, letting them use it themselves, letting them make mistakes so that they can critically think their way through driving the ambulance in the wrong direction. Or I've never set anyone up to fail, but, like, if they don't restock something and we get on a call and I'm like, "Oh, where's this?" And they're like, "Oh, I don't have that." And I'm like, "Oh, maybe you shoulda checked your ambulance a little better this morning," 'cause that's how I learned my lessons, right? I'm like, "Oh, I need this. Um, Crap, I didn't stock my ambulance appropriately." Stuff like that, I feel like, um, helps them a little bit more, so then when, um patients do crap out on them, they're able to that's all muscle memory at that point, and the medical is what they can focus their thinking skills on.
Yeah, I like that you said you have to let them fail. You do. You're there as a safety net so they don't hurt anyone, but sometimes and it sucks to do as a
Yeah.
preceptor because you know you're all gonna look stupid. But
Right.
sometimes you gotta let them learn the hard lesson. Like, I had this 60-year-old female with a history of all these cardiac problems. She had a near syncopal episode. Her sats were like 89%. They got better on oxygen. And my student he was doing all right. And just out of nowhere, he's like, all right, I'm going to call the doc and downgrade this to BLS. And I was thinking, like, you're what?
Yeah.
And I was about to say, like, fuck no, you are not calling that doctor because we are all going to look stupid. But I was like, you know what? This is a lesson that he's going to have to learn. So I sat there and I watched him get his head ripped off for trying to downgrade this patient. Sometimes you got to let them make the mistakes and learn the hard lesson. But I think before you do that, like you said, you've got to make sure they know the ops, like how to use the stair chair. I
Yeah.
cannot tell you, I work in a two-tiered system. I'm in a chase car and the BLS are in ambulances. I cannot tell you how many times I have watched a early 20s EMT try to figure out how to use a stair chair while there is a 350-pound patient teetering at the top of the steps. And it is like, I used to get mad at them. And now I am gentle with them. At least I think I am. And I show them how to use it. I'll take over and I will show them how to use it. And then I will call their supervisor and be like, how the hell does this person not know how to use the fucking stair chair?
Right. And when I first started working EMS, I worked in, um it was called, it doesn't exist anymore. It was in New York, and it was in Newburgh, New York, which is, like, not a fantastic area. Um, but they didn't really teach that stuff. Not that it's their fault. Theirs was very much like a sink or swim kinda system. Like, you go in there and you figure it out. I was there for 10 minutes, and I went to, um from me being educated now, I'm pretty sure it might have been like a COPD, CHF exacerbation that coded in front of us. And I'm sitting there, I don't have gloves on. And the guy's like, "Do you know how to do CPR?" And I was like, I got my BLS card like 2 weeks ago." But sure,
Great.
yeah, do
Great.
CPR. And they were like, "Get the IO." And I was like, "Yeah, I don't know what that is. I'm really sorry." I could do
Wow.
CPR though. I have like no gloves on, EMT. And we used to wear like the cop pants with the button down blue blue shirt. Like I mean, we look like I looked like
Mall
a fish
security.
look like Fisher Price costume for Halloween because I was a child. It was very embarrassing. But when I went to go work for AMR in New Haven, we had someone that trained us how to use the stretchers and the stair chairs. And when he was training me, I thought he was the meanest person I've ever met in my life. He was so mean, and he would fail you if you didn't know how to use the stretcher. Like, the buttons are great and everything like that, but when they fail going in and out, do you guys know how to, like, troubleshoot it to make sure you can take the patient out of your ambulance? Because if it gets stuck in the ambulance and someone's working a code and your job is to lower the stretcher and it's stuck in there and you're like, "Oh, okay. Well, now what?" Like, you know what I mean? And they're stuck in there. So he used to drill it, and he would not let you get on the road and be cleared to work with another person until you proved to them that you knew how to do stuff like that. And
Is he
thank
still
you to
like
him,
that, or has he gotten in trouble for being mean?
he has gotten in trouble for being mean, I think. I think he's been spoken to gently, like, "So and so complained about you," and he was like, "Well, tough nuggies, like, they need to learn." And I am so thankful for him because if he didn't treat me like that when I was 20 years old, I would have never learned. I
I
would have
see
never.
I see an amazing lack of resiliency in some of the people who are coming out into the world to train, both on ground coming out of school and also I shouldn't say I see it on flight because I haven't seen it on my particular team, but I know people who have seen it on their teams. Just these people who come in and they're like, "Oh yeah, I want to learn. Like I'm happy to train with you." And then you give them constructive criticism and it's not going to be pleasant. I mean, it's like
Yeah,
getting a tooth extracted. You need to have it done and it's going to benefit you, but nobody thinks it's fun unless you're a sadist.
yeah,
Uh, I think where am I going with this? Nobody fails orientation anymore. It is very, very rare that that happens. People get pushed through. I'm I am an old man now. I am approaching my mid 40s. It's happened in a blink of an eye because I distinctly remember being 23, hired at my first department, going through the FTO process and thinking, holy shit, I am getting married. I bought a house and there's no guarantee that I'm going to get off of field training. Like I might get booted out of this department and have to find a job. And that just doesn't happen anymore.
no. And
I don't know. Does it?
not that it should happen.
I
I've never seen it happen. We've had I know people that crash ambulances over and over and over and over again and still have jobs. And it was in their first 6 months being hired, brand new EMT. Like someone that probably like I don't even know how do you get in that many car accidents and still have a license? Like, do you not get points on your license for you know what I mean? Like, I just don't. There has been people like that, and then there's people, um, I just I I don't think I think that a lot of people that train them don't put the effort in that they should, as in with the
good point.
constructive criticism, like telling them the truth instead of just saying, "Oh, you're really good at telling grandma she's gonna be okay. Great, fantastic, but you can't drive the ambulance safely code 3 to a hospital." Or if I need help, you don't know how to ask for it on the radio, or just things like that, like moving, lifting the patient in the stair chair. I can't carry somebody down the stairs alone. I need you to help me, but if you don't know how to do it the right way, then I'm by myself. Things like that. Um, you need to tell them what they're bad at, and not just what they're good at.
I think one of the worst things that a field trainer can say that I have heard people say time and time again is, well, they'll tell them some things that went wrong that weren't optimal. Like, well, this happened, but you got them to the hospital alive, and that's what really matters. It's like, no, like, yes, you want to get them to the hospital alive, but we are better than that. Just be a fucking Uber driver if that is the end goal. Well, you got them there alive.
Yeah. And a lot of the arguments that I see, in flight and ground is it's really not medicine. like the people that don't know what they're doing, it's really not any of the medicine or any of those decision making. Like it's more of like not being able to put the thought with your hands, like react fast enough. But it's a lot of it's ops things, like walking into a tail rotor or um knowing like the process to put the vent and then the other thing in the aircraft or things like that. Or on ground, it's just like situational awareness. Don't walk into a crowded club by yourself while your partner's behind you at the fire department. Like maybe don't do that. Or like just things like that is what I've noticed a lot of the ones that get pushed and like maybe once or twice being repeated through orientation is some of the medicine, but when people are getting pushed over and over and over and over and over again, a lot of it is like the maturity of adjusting to the lifestyle that the job is.
I could not agree with you more. And it
Like
is
if they can you put them in a hospital and they see someone that's satting low, they know to go get a non-rebreather and put it on them. But for some reason, you put them in an ambulance in someone's front yard with the fire department there and someone's significant other yelling at you. They don't understand that. I don't
yes.
know.
They cannot manage the scene. They cannot prioritize. They cannot execute. It's hard to train that. I've done a
Yeah,
couple of episodes recently where I've tried to like look at this, like answer this question. It's not hard, and I agree with you. Some people just aren't going to get it. Like I've thought trying to answer the question, what has worked for me? I'm not trying to like touch myself here, but I've never had an issue with that. Like I've always just naturally been good at managing a scene and managing the flow. There's things I haven't been good at that I've had to work on, but that hasn't been one of them. And I have struggled as long as I've been training people to try to figure out how to get them to get it, for lack of a better term.
right. Give you
Yeah.
some advice here and there, but I'm really not someone I'll sit there quietly until there's like someone is literally like screwing up, like
Well,
and then they're like, "Well, why didn't you say anything?" And I'm like, "You're doing just fine. I mean, it's not the medicine." Like, I'm always gonna tell you, like, "You should have moved things along faster in the house. Like, we were here for 30 minutes. There's no need for us to be here for 30 minutes. Like, let's move along that way and move the call along." But then I said, like, I'm really not the one because I I don't have the patience for a lot of that training, but I am very upfront about that.
I think
When
you
it
might be the one though. As you have, not trying to fluff you up here, but as you have been talking, how long have you been doing this?
uh 11 years.
All right. Like you have said things that have shown you have a lot of experience and that you have matured and evolved. And that's been something I've evolved to also. I am not anymore the type of field training officer who's got somebody on a tight leash and I'm barking at them to do this. I think that shows immaturity and maybe not immaturity, but a lack of experience and like being unsure of what you're doing as a preceptor. I very much now am of the mindset that like adequate is okay.
Yeah.
You know, if you're getting the job done, you're not hurting them. Sometimes it's not going to be pretty. It might not be the way I do things. It may not be the treatment pathway that I necessarily would go down, but it's not wrong. And if they want to do that, rock on
But
out with it.
yeah. Um, yeah. I just I have told them, like, "These are some tricks that I have if you want them." Like, when I give a narcotic, I always put an end tidal on because it's telling me if they're like not breathing or breathing, things like that. And I do that in flight too. Just like little things that I do for patients to make my life easier. And I said, these are tricks that I have. And I'm sure you've learned tricks from other preceptors that you've had. Um, but remember that like your style is your style and you're not going to be good at this acting like somebody else. So like take these tricks from everyone and put them together to make you who you want to be as a provider. Not necessarily like a specific provider, because that's what I did when I went through medic school. I had a preceptor that was extremely aggressive medically, like very, very, very aggressive, and he still is very, very aggressive, and I was like, "I'm not aggressive like that." So I took the little soft pieces I learned from other people, and then I took, like, the tricks he showed me to know when someone, like, an assessment kind of like when you see this, you know this, or when you see this, you know that.
I think the wise medical provider is keenly aware that's most of the maybe most of the time, less is more. I see these quote unquote aggressive people, and I'm like, are you actually treating the patient or are you using this as a platform to impress yourself?
Yeah. Or are you scared they're gonna turn crappy on you and you're not gonna react well when you're put in that situation last minute? That's me. Like, I don't want them to turn bad on me and I'm, like, not paying attention and don't even notice.
Oh yeah, but
But
that's stuff you've learned over the course of years, your gestalt and heuristics. You're like, I've seen this before. I've seen it go south this way. I'm going to do this and prevent that from happening. That's a lot different than, I mean, to use the easy airway example, I have seen paramedic crews and the ERs too paralyze people and intubate them that were doing just fine sitting up with a nasal cannula on their nose.
yeah.
And it's like, what are you doing? Like, are you doing this because you're trying to impress yourself because you wanted to do the skill?
Yeah. Um,
I'm
I
actually
don't
going to
know.
be talking about that at Resus X. Shameless
Oh.
plug for the conference.
Yeah, I haven't intubated somebody in a long time, to be honest with you. It's really not as common as it used to be.
No, it is not. That is,
Yeah.
I think, a double-edged sword. It's a good thing because I think we were tubing everybody who sneezed and twitched at the same time. And we were like murdering people who were in compensated shock. And we were like, look how good we did. We got a tube. You know, we secured their airway, but they like at the expense of their hemodynamics and their life.
Yeah.
But at the same time, because we're not doing it as much, I definitely feel it myself that I'm not, maybe not as good at the skill as I used to be.
Yeah. A tube, I always get nervous during a tube, and it shows.
You should. Everybody should.
My leg ticks like a dog, and I used to have keys for narcs, you would hear them, and they'd be like, "Kayla, are you nervous?" "Yeah, I'm nervous." "What if I don't get it?" Which one of you is gonna get it?" "Nobody, because 'cause you're all EMTs, and it's just me." Like like, "If I don't get it, are you gonna get it?" And they're like and then a lot of our partners are like, "Well, I got my EMT card when we used to be able to intubate," and I'm like,
Oh,
"Right."
shut the fuck up. Yeah. Uh-huh. Okay.
I bet.
Yeah.
And
I hear
ATM
that.
too.
I guess a lot of them have like retired off or died off. But if I heard one more EMT, like back in the day, I used to start lines and I used like, shut
Yeah.
up.
And
No,
then why did you
you
go to medic school if you already
didn't.
know how to do it all? That's what I tell
True
them.
that. True that.
If you're so good at it, why didn't you go to medic school? But,
Don't get
um,
me started on
that's my
AEMTs.
sassy attitude with the firemen I used to work for. They all know
Yeah.
though. They all know the attitude I had.
Yes. Another thing I like, and somebody's going to get butt hurt that listens to this, but I no longer let them do crike pressure anymore
Oh, yeah.
because they will apply Ted Bundy style serial killer choking to the patient. They're like,
Like
"Hey, Crunch, you want some crike pressure?" I'm like, "Yeah, sure." And I'm
like this.
like, what the fuck are you doing?
Yeah, no, I don't
Like now you've broken their hyoid bone.
yeah, and then afterwards, you could, like, tease them. At least they used to laugh at you when you would tease them, because then they had, like, good senses of humor mostly, most of the time when I worked for the fire department. A couple of them had some good sense not all of them, but
Firefighters get butt hurt a lot.
oh, yeah, they do.
Big
But then
tough
when we
firemen.
but then we go to a fire, and I'd be like, "I'm following you guys," and they were like, "Yeah," our one structure fire a year. I'd be like, "I'm following you guys," and they're like, "Finally, Kayla has to do what we tell her."
There you go.
I'm like, "Well, yeah, because I mean, I'm not trying to get stuck in there."
All right. So let's see if because we're coming upon like 45 minutes. If you had to give one or two pieces of advice to somebody who is precepting or new to precepting, what would you give them?
Like, as a preceptor, I think that
Yeah.
when you get someone that has no experience, like a brand new EMT or even a brand new paramedic, because there's a lot of zero to heroes, even a brand new flight paramedic, I think that orienting them to their apparatus, aircraft, and ops, and letting them do that for shifts and calls at a time, and letting them get comfortable with that process, loading the patient, even simple, putting them on the monitor, talking on the radio, the whole ops, your walkarounds, everything you do, have them do just that stuff and not focus on the medicine. so then they're comfortable in their atmosphere, and then tack on your medicine after you notice that they have a flow and they understand the way a call works, then start tacking on the medicine. I think that puts them in a better headspace to truly think critically about medicine. That's one of my biggest pieces of advice, 'cause that's something that I noticed from 2 aspects of learning, that the ops once I'm comfortable where I'm working, then I can show you what I truly know.
I have been thinking that for a very long time, but have never been able to put that into an eloquent phrase, and you just did it.
Yeah. I've been thinking about this for a very long time, and my most recent experience has really, really honed that in on me a lot. Like, 'cause I had to even being someone with experience coming to learn a new atmosphere and a new company and kind of a new way, a new process of things, acted like I had no idea anything about medicine because I was nervous about the situation I was in because I didn't understand it.
So make them be familiar with their environment and then tackle all the cerebral shit. I like
Yeah.
it.
And if you have like, something that I also you don't have to sit in someone's house and fix them. It's okay to take them into your safe space of your ambulance and fix them there.
You don't say.
Yeah, like, if that's how you of a provider, if that's how you create a safe space for you, that's fine. There are things, obviously, like, and they're stuck in a car, or it's a really large person stuck on the 19th floor of an apartment. I understand that. But if you can get someone to your ambulance and then put them on CPAP, you can do that. That's okay. That's your safe space. That's where you work. And I think that's okay. Like, I think that people perform better. It's kinda like a hospital. You see nurses do so well in a hospital, or doctors do so well, and we're like, "Well, yeah, they're in a controlled environment." And it's like, "Well, yeah, you have a controlled environment too. It's outside, parked outside the house."
Well, very insightful, Kayla. Do you have anything else you'd like to add?
I don't I just really think that, um, if you give people, like I said, the opportunity to get comfortable with their atmosphere, they can show you, a lot more about what they know. And I feel like that happens a lot in our field.
True dat. Well,
That's
cool.
all I got.
Thanks for coming on. I think it's a good place to
Thanks for
stop.
having me.
Hold on, I'll
I
stop this real
appreciate
quick.
it. Okay.